And I'm going to start now.
Thank you, Erin. We have a couple of minutes before the webinar will start. I'll let everybody get joined on. We'll go ahead and start with the introduction. My name is Kathryn Tucker. I'm a registered dietitian and contractor to the Administration for Community Living. Welcome to the third event in our Food Insecurity Education Series. Today's event will focus on screening for food insecurity. Food insecurity has been an important topic for decades, but for the last few years, it's really brought a lot of attention around the issue. Next slide. By the end of today's webinar, you'll be able to define and characterize food insecurity, identify the importance of assessing food insecurity, explore the different food insecurity screens, and learn how to measure food insecurity and discover potential assessment and training resources. Although today's webinar will focus primarily on screening for food insecurity, making the connection to intervention is important, and we'll focus on intervention and referrals during the next food insecurity webinar in October. And I'll talk a little bit more about that later. So next slide, please. I'm really excited to introduce my co-presenter today, Dr. Temitope Walker. Dr. Walker, please tell us about what you do.
Thank you, Kathryn. I am the Senior Hunger Nutrition Coordinator for the Georgia Department of Human Services Division of Aging Services, Georgia State Unit on Aging. I coordinate the implementation of Georgia's first state plan to address senior hunger. I work closely with local and state agencies in Georgia to help raise awareness about what critical practical solutions are present to address senior hunger. I also continue to publish my dissertation work on the nutritional and financial implications of SNAP benefit receipt among SNAP eligible older adults. I'll hand it back over to you, Kathryn, to move us forward in this series on food insecurity screening.
Thank you so much, Dr. Walker. Next slide. Food insecurity occurs when nutritionally adequate and safe foods may not be available. It is limited or uncertain availability of adequate and safe foods, or a limited or uncertain ability to acquire food. I will talk a little bit more about that in a minute, but insecurity is not always economics related. Next slide. There are two types of food insecurity. For example, those experiencing low food security have food, but it's nutritionally inadequate. This can lead to nutrient deficiency and malnutrition. Those experiencing very low food security have reduced food availability that can lead to skipping meals, not eating. For example, not having enough funds to purchase food. And then this type of food insecurity is very serious and could lead to very detrimental health conditions. Next slide. First, we must remember this: food insecurity is not always linked to economics. An older adult could be food insecure due to having limited ability to cook or obtain adequate amounts of food. I've also heard comments like, well, she drives a BMW, so she can afford food. What we don't know is that car's been paid off for years. Her significant other has died. Her income has now decreased by half, but all the same household bills are still there on half the income. So food insecurity can happen literally to anyone. Food insecurity can be long-term or a temporary problem and is influenced by factors that include the items that you see here on the screen. We'll start with income, and the risk of food insecurity increases when money to buy food is limited or not available. In 2016, 31.6% of low-income households were food insecure compared to the national average of 12.3%. Some people may have a higher risk due to limited employment opportunities, and being low wage earners or being disabled and or having increased health care expenses, which that can also lead to limit their ability to buy food. High unemployment rates among low income populations make it more difficult to meet basic household food needs. Now, as far as disparities in 2016, Black non-Hispanic households were nearly 2 times more likely to be food insecure than the national average. It's 22.5% versus the 12.3% nationally. And among Hispanic households, the prevalence of food insecurity was 18.5%. LGBTQ communities are facing food insecurity as much of their poverty rate is higher than the national average. Older women are more likely to identify as food insecure compared to older men, and widowed women often live years with limited finances. And older adults, divorced or never married, were also more likely to experience food insecurity. People living in some urban, rural, tribal, and low-income areas may have limited access to full-service supermarkets and grocery stores. Often neighborhoods have fewer full-service supermarkets, and convenience stores often lack variety and quality food items, and they're also much higher in price compared to the grocery stores. And these areas are often called food deserts. When we're dealing with transportation, we have to understand that the distance to grocery stores or food programs can make it very difficult for consumers to get all the supplies that they need. Public transportation may be limited, especially in rural areas, and walking may not be an option. Also, transportation may limit the number of bags that you're allowed to bring, and older adults may have difficulty even carrying those bags. Older adults may not be able to walk at all or walk long distances. And even in rural or urban areas, a person could walk over a mile to the closest supermarket. People who cannot go outside the home or by themselves or drive to the grocery store may be less able to access adequate, safe, and nutritious food. Older adults may have limited access to their children, family, and community members as social supports, and informal contact with family, friends, and community members is needed to maintain a food security status for the aging population. They've also found older adults who rent are more likely to be food insecure, and in 2019, 20% more renters were food insecure than homeowners. And finally, lower literacy skills can have a detrimental impact on nutritional status. Next slide. Research has found low-income older adults reported lower nutrient intake, and food insecure older adults were 2.3 times more likely to report poor and fair health, more likely to experience depression, and more limited to activities of daily living compared to their food secure peers. Food insecure adults may be at increased risk for obesity due to lower quality food that costs less but are higher in calories and higher in calories and fat and lower in nutrients. And there are higher rates of chronic disease in low-income food insecure adults. And many note they invest less in their health and have less adherence to medical treatment to help stretch their funds further. Food insecurity can also affect how someone heals from surgery or health conditions. For example, food insecure adults are 78% more likely to experience depression. 78%. They're 40% more likely to experience chest pain, 55% more likely to develop asthma, and 10% more likely to experience high blood pressure. They're 21% more likely to experience limitations in activity. How food insecurity affects health is important because an increase in medical expenses can further limit the funds to buy food. And additionally, food insecurity can cause malnutrition, which can also mean a deficiency in certain nutrients and can cause increase in weakness and falls. Next slide. The importance of food insecurity screening. To start, we want to look at identifying and assessing the extent of food insecurity is important for program and policy development. Most state units on aging do not focus on food insecurity when implementing the Older Americans Act nutrition program and their regulations, their policies, procedures, targeting, prioritizing, and state plans and initiatives. Research on food insecurity is limited among older adults, and screening for food insecurity can be critical for program evaluation. Program interventions can be significantly informed by screening for food insecurity. Knowing the severity and specifics of what is assessed on food insecurity screens can help with public assistance referrals, such as those for emergency food and SNAP benefit applications. More than anything else, it allows us to identify those who need more resources so we can help to improve their lives and health, thereby fulfilling the purpose of the Older Americans Act. I want to now turn over this presentation to Dr. Walker. I'm so excited to hear about all the food insecurity screens and her background in this. Next slide, Dr. Walker, you can take it from here.
Thank you, Kathryn. So I'll be talking about how we assess food insecurity at the state level in Georgia. But first, I hope this slide reminds you of the big picture. The goal is to assess food insecurity, identify the factors that potentially influence food insecurity, and then address those factors. This process is likely one that will be repeated over and over again because the solutions are many and complex. Next slide. So how do we measure food insecurity? So food insecurity is measured as a household level concept that really refers to uncertain, insufficient, or unacceptable availability, access, and utilization of food. Don't worry, that's a mouthful, but the questions really get to that. Next slide. These are the 4 modules that are used to assess food security that I will highlight today. The USDA 18-item food survey. You also have the 10-item. We'll talk about the 6-item, the short form, and a variation on that. And then the Children's Health Watch Hunger Vital Sign 2-question screening tool. Next slide. The USDA measures food insecurity through responses to a series of 18 survey questions and statements fielded to roughly 45,000 households in the food security supplement of the Census Bureau's current population survey, so the CPS module. The first item addresses worry about food running out, while the remaining items address possible reductions in food intake because of financial constraints. 8 of the items are focused on children. So here's a key distinction of this longer form, and thus is used for households with no children who are under the age of 18. The items include, I worried whether our food would run out before we got money to buy more. This is considered the least severe. Did you or the other adults in your household ever cut the size of your meals or skip meals because there wasn't enough money for food? Did you ever cut the size of any of your children's meals because there wasn't enough money for food? And did any of the children ever not eat for a whole day because there wasn't enough money for food? So the last question really gets to the most severe severe cases with households with children. Next slide. So the 10-item food security survey module really gets at a couple of things here, which it starts really with, we were worried whether my food would run out before we got money for more. And then really looking at, oh, sorry, forgive me, that's your header. Next slide, please. So this 10-item questionnaire really has some key parts to it. And the key one, of course, I do want to mention is that it's certainly less burdensome than the 18. There are no questions about food security. So I read through those that are children specific, so you see those. It improves comparability between households with and without children. And the limits include that there's no information about food security of children if there are any in the household. Next slide. So next, we'd like to take a look at the 6-item short form of the food security module from USDA. So as you review the questions, what you see is that if someone answered yes to number 3, as an example, in the last 12 months, did you cut the size of your meals or skip meals because there wasn't enough money for food? You would then ask, how often did this happen, as an example? Next slide. So the USDA 6-item short form survey module has 6 questions for respondents to answer. And also it has its advantages and disadvantages. The advantages, of course, include that there's certainly less burden than the 18 or the 10. It identifies food insecurity and very low food security. There's a high specificity and sensitivity, and there's minimal bias. The limits, of course, include that it does not measure the severity of those levels of food insecurity. Next slide. So finally, we're finishing up with the Hunger Vital Sign 2-question screening tool. This question survey was developed by Doctors Aaron Hager and Anna Quigg and the Children's Health Watch team from the U.S. Household Food Security Survey. It was validated for both youth and adolescents in 2015 for that age group, and then validated for adults in 2017. The individuals are asked to respond by answering often true, sometimes true, or never true. If the response to either statement is often true or sometimes true, the individual is identified as food insecure. So question 1 would be, within the past 12 months, we worried whether our food would run out before we had enough money to buy more. And then the question 2 would be, within the past 12 months, the food we bought just didn't last and we didn't have money to get more. Next slide. So this 2-item tool really has some key factors here. What we know is that there is a 97% probability of screening positive in low-income homes, 83% probability of screening negative in food secure homes, and 97% sensitivity among adults and young children. There also 74% specificity range among adults. It's easy to use in clinical and community settings and can be administered verbally or in writing, and is available in many different languages. So there's a lot of advantages here. Next slide. So this tool, like others, in its advantages has its disadvantages too, but the advantages include that it is less burdensome. There's a high level of specificity and sensitivity, and has been validated for children and adults. Of course, the limitation is that it does not measure the most severe levels of food insecurity. Next slide. So what do we do in Georgia? Georgia has been using a validated 6-item food insecurity measure since 2011. It has found statewide food security, oh, forgive me for that, found statewide food insecurity statistics of clients comparable to federal statistics, identified critical unmet need for nutrition services, shown the significant contribution of receiving nutrition services to achieve food security, and highlighted the difficulty in meeting basic food and healthcare needs of food insecure older Georgians. Next slide. So these questions are about the food eaten in a household in the last 30 days and whether you were able to afford the food you need. And so we use these questions for all of our clients who are requesting meal services. And so this is what you may notice, this is slightly different from the short form that I showed you in the previous slide. So this is modified with just a very subtle difference. And what I want to highlight as a difference here is that the key part is that there are 2 questions that are slightly different, and you'll notice this here. After you get past the first 2, it says, in the past 30 days, as question 3 there, did you or others in your household ever cut the size of your meals because there wasn't enough money for food? So it really splits out the questions that were together in the original form. And then it goes on to, in the past 30 days, did you or others in your household ever skip meals because there wasn't enough money for food? And then it goes on with that same format of looking at 30 days from behind with key parts that I want to highlight, which is getting at cutting a meal, skipping a meal, not having enough money by eating less, or going hungry altogether. So those are the 6 items that we use. For the first 2 questions about the ability to buy food to last and to afford a balanced meal, the categories are often, sometimes, and never. The remaining 4 questions really get at those key things. So the size of the meal, skipping meals, eating less, going hungry, and have a dichotomous scale of no or yes. The left column has the questions on the survey, and the right column indicates how the survey takers can respond. Next slide. Results of this tool are scored using a sum of affirmative responses, often, sometimes, and yes. The food insecurity summary score, which is between a score of 0 and 6, is calculated, and the individuals are classified into one of the 4 levels. So either food security, marginal food security, low food security, or very low food security, or one of the 2 levels. So you can see there's 2 distinct ways at which you can now cluster those who are responding to the food security assessments. And you see that divided by the line. Next slide. So knowledge is power. Knowing not only how the assessment is scored, but knowing how the questions tell you something about the severity of food insecurity helps those administering the assessment and evaluating it think about what the implications are of the responses and what that means. Answers to these questions can give an indication of how severe a respondent's food insecurity is. For example, least severe. Was this statement often, sometimes, or never true for you in the last 12 months? We worried whether our food would run out before we got money to buy more. The most severe case would be in the last 12 months, did you ever not eat for a whole day because there wasn't enough money for food? Next slide. So when looking at when to actually do assessments of food insecurity, time points are really based upon state and agency requirements. And in looking at that, those time points could be at initial intake, and certainly should be, in conjunction with other relevant assessments. So oftentimes if your Aging and Disability Resource Connection group, or ADRC in general, you may have a different format there, and how that those other assessments may be part of that larger pool of assessments. When identified by concerned staff or volunteer during reassessments to see what changes may have occurred, and then when services change. Next slide. So in looking at what potential assessment training resources there are, you want to make sure first and foremost that you review your state and agency policy first. There may actually be training available there for it. The USDA food security survey modules are standardized and provide a straightforward process in how they should be administered. You want to make sure that you check out the validated tool that is currently in use by Georgia, and that reference will be made available to you. And you should also see the session's takeaway sheet for additional resources from organizations like Feeding America and the Food Research and Action Center, FRAC, and some critical papers from food insecurity experts that will be provided. And now I will turn this presentation back over to Kathryn.
Thank you very much, Dr. Walker. And thank you for sharing your wealth of knowledge surrounding food insecurity and screens. Food insecurity, we know, is an issue among the population we serve. And to truly make an impact and address food insecurity, we need to have the data to show the need. Data is a way to identify the needs, but it's also a way to show the improvements and the outcome results. If we don't know where we started, it's going to be really difficult to know whether or not we've made a difference. And I encourage you to choose at least one of these takeaways to start the process. First, use a validated or reliable food insecurity screen that meets the needs of your agency, but also take in consideration the feasibility of your agency to conduct the screens. Recognize that food insecurity screens should not be used alone. Many states use several screens in conjunction. They may use a malnutrition screen with the food insecurity screen. You want to determine how often you'll perform assessments. Teach your staff how to identify participants at risk and look for risk factors. Understand the ways the assessment of food insecurity can be of value to your program and policy development, implementation, and your evaluation. Provide staff training on food insecurity and how to assess it. Next slide. The recording from today and the past webinars presentations are available on the NRCNA's website. You can see the link at the bottom of the slide. During this series, we have highlighted collaboration, promising practices as state units on aging, and identifying food insecurity. The next webinar will be in October, and we'll close the circle by identifying referrals and interventions for older adults who are food insecure. A link to the next webinar will be available and included in the post-webinar email with the recording of this webinar. Next slide. Finally, we did not seek prior approval for this event for CPEU credits for dietitians. You can still receive credit under the CPE activity type 171, teleseminars and webinars. So please visit the CDR website for further instruction. And after completion of the webinar today, you'll receive a link for a post-webinar evaluation. Next slide. So I am extremely excited to open this time up for questions. I really feel like we'll have plenty. If you have any questions, please put it in the Q&A. We probably have a couple of questions in there already. And also after a post-webinar, if you have any questions, feel free to reach out to myself or Dr. Walker, and we'll be happy to answer any questions that you have. Okay, let's see what we have in the Q&A. So our first question is, on the modified 6-item survey for Georgia, wouldn't question 3 and 5 be similar and question 4 and 6 be similar? Dr. Walker, I didn't know if you wanted to answer that for me.
Yes, I don't know if it's possible to go back to slide 21, but I have it in front of me, but it might be helpful to see the subtle difference here. But if not,
yeah, we can move it.
Okay. All right, so in question 3, it's a subtle difference, but we're really talking about behavior here. So the very question 3 is talking about actually just the simple act of cutting the size of the meal, which and question 5 is really getting to that the feeling and behavior. So did you ever eat less than you felt you should? And really gets at more of what the act is of cutting, whether it's a half or a third or anything like that, and more getting to, okay, in that act, was there something with that, if that makes a difference. So it's a very subtle difference, but it's really getting at, okay, are you cutting or doing something? And then also as a catch-all is like, okay, in that act, did you know that you were eating less? Hopefully that helps explain. The other one is about whether, I believe 4 and 6 are similar. So you can certainly skip meals, but the very act of going hungry, then we start to get to that physiological, emptiness of not having anything. So maybe you skip a meal. And so instead of having, 3 meals in a day, you have 2 instead, which is different than maybe going hungry where you're not eating at all. So that would be the way to sort of distinguish those. But yeah, after a while, you start to say, are these the same? But it's a very subtle difference between those.
Yes. So there was another question, I think, that dealt with the same thing in Georgia's short form. How are these 2 questions different about the cutting the size of the portions of food eating, or I'm eating less? So yeah, I think you answered that. Let me go on down. Who conducts these assessments? Would it be the AAA or the senior nutrition programs?
It's actually both. So you can get, if someone is calling in through intake, through, as an example, ADRC, they could do the assessment there. And then of course, if you have a person, because we do it at reassessment, as well. And so that might actually be, now that you have somebody who's in the system, you would have that happen at your case manager level, or those people who are working with that client once they're in the system. So yeah, so you have different people who are able to do that same assessment.
Okay. Next question is, what additional nutrition screenings are done at intake in Georgia? Are these done for home delivered meals and congregate?
Yes. So right now the push is really to do the 6-item questionnaire with our home delivered meal clients. But of course, everyone's getting it at intake. We've been able, since 2012, all clients have gone through that assessment, but we've been really in talks about whether we could streamline in that some way. But of course, me being the research head, I'm like, no, do everything. But we recognize with all the assessments and everything else that has to happen, there's a fair balance here. Of course, the other things that we're looking at includes, whether there may be some issues with eating, where we're talking about missing teeth, issues with chewing, other factors like that. So we're not giving somebody a meal who has some other factors. DONR scores, nutrition screening initiative screenings are done as well as part of that. And so it's kind of one of those things where we have some different triages, but all of those are taking place. And of course, with that, people are coming, if they're coming in for intake, might ask about supportive services, right? So access to SNAP benefits and other things like that. So those component factors may come into play.
Okay, we have this next question. We have found that asking these questions become a time consuming for the client to do with the subtle differences. Does modifying how the questions are asked, does it impact the validity of the screen?
Well, the big answer would be yes. If you don't ask the questions of how they're framed and validated in this way, then absolutely you would have to make sure you're assessing, you're able to, you wouldn't, the way in which it's assessed and then also how we interpret that is really based on this exact framing. I know that having done this myself with clients, it does kind of seem, okay, are they asking me the very same question? But we have been able to show that with a large number of people providing this screening, that people are making distinctions of the responses that they're giving. So for the most part, I'd say that it's really every 12 months, unless you're changing a service, that you're getting access to this. So I don't know how often you might be doing this screening, but we just kind of say, bear with us as we go through that. But yeah, if you change it in any way, then you really have to kind of validate it as you've modified it.
Awesome. We have another one. Are there steps to changing the language when discussing food deserts to food apartheid?
Well, in our context, I'm amazed by how do I say this? We can get into whether we're talking, was it nutrition security, or there's like there's a huge wealth of terms that we can use to describe this. For us, we've not really got into how do we frame this. So this is actually kind of a cool question, because in the last session of our Georgia Senate, we had a study committee that looked at food deserts, and then it was like, you say food deserts, and then people said, hey, well, we should call it this, we should call that. And really the reality is, and maybe I'm scapegoating the question here, is that it's really about identifying the solutions to whatever you call it, right? But we have not gotten to food apartheid, but we're really just trying to identify who do we need to have at the table. So forgive me if it sounds like I'm kind of dancing around that, but I know there's a lot of terms that people are trying to use to kind of make it more friendly and welcoming, as opposed to what desert might imply. But I think we've really got to get to, what are the variables and reasons for why there may not be enough access to food in the way that we would like to have it in those spaces, as opposed to how we term it. So,
Yes. So can you distinguish the difference? Okay, we've already answered that one. This was, can you distinguish the difference between between the questions in the 2-item survey? So that's the vital sign survey. So I guess they wanted a little bit more information about the 2-question survey.
let's see.
And that was the next slide, the 22, was it? I think. On down, maybe. Or it may have been on up with the one more.
Okay, so
there it is. Yeah.
essentially, yes. So with the, yeah, perfect. Okay. So the way this is really framed is that if a person is asked, it responds, how would they put it, as either often true or sometimes true for either one of those questions, that person is identified as food insecure. So that's kind of how it works. I can personally say that I've really fought hard within my division to not move to the 2-item. No disrespect. I really think it's great in the clinical setting, but I think for those of you who are in a framework by which you are potentially providing meals or the supportive services which are identified as what you could use to solve food insecurity, that by having a larger number of questions that kind of tease out the level of severity, and maybe even start to think about what some component surveys and questions you should ask, that would provide you more value when you start to look at what the implications are in what your solutions might be to why a person might be food insecure. But I get it in a clinical setting. If you're seeing clients at 15-minute increments, next, this way is a great way to say, hey, let me do a quick screen for this purpose. But hopefully I've not offended anyone. But yes, that is kind of how you distinguish those.
The next question sort of leads into that. So their question is, if you were to ask the 2-question survey and they were to test positive, would you recommend then for them to ask the rest of the remaining questions? So that would be where you would go, if they did test positive, then you could ask more questions. But I think if you're going to go to that route, you might as well go ahead and ask all the questions that's in at least the short form, the 6 short form.
Right. So, okay. So let me clarify something. You kind of have to commit. So it's not really set up to where you have a 6-item and then you say, okay, well, based on these, not in real time are you making assessments of whether you think someone's food insecure based on just responding of those first 2. You really should commit. If you're going to do 6, commit to the 6 and go through, because it does allow for that distinction of what a person may be doing when you talk about the level of severity of someone just outright not eating at all, versus, because even in this quick clinical setting kind of tool, which is a 2-item, once you flag that, there's still another step, right? You've got to figure out, okay, they said they're food insecure, now what, right? So in that clinical setting, is someone, are they referring them to someone else? That clinic could be referring them to you if you are providing nutrition services, right? And so you then wouldn't ask them those first, you could ask them those first 2, but clearly they were referred. So there's more information you're wanting to gather. So it's not one of those that in real time, the purpose of you really understanding and in this session, providing you an understanding when we talk about level of severity and kind of seeing what is it telling you about food insecurity, is for you to understand that there is a unique distinction of what these questions can tell us, and that there is some scaling and ways that you can kind of categorize and determine those who maybe that you need to have some more immediate action items for versus others in that. So I want to kind of keep that in mind, that it's not something in real time that you're like, oh, okay, first 2 I see, oh, you commit. If you're doing 6, do the 6. And then at the end, you're looking at scoring. So hopefully that helps.
I told you we were going to get a lot of questions. I'm so excited. So this is another one. In Georgia, does the data from reassessment get analyzed at the individual level to ascertain what has changed relative to the food insecurity for that individual since program enrollment and delivery of benefits? So what are you seeing as far as the difference there now with the resources that's been identified and assessed or accessed?
Oh, okay. I wish I had taken a few notes. That's many part of the
That's a
question. I
lot,
love it
yes.
though. Yes. Okay. So let's see.
So
I want to be.
how are you analyzing it? And as
Gotcha.
far as the follow-up, like, are you seeing a difference with that data?
Gotcha. Okay. So this tracked very well with us. Georgia in the past, and I guess now currently, just in this pandemic period, was in the top 10 for seniors who are at risk of hunger, who are food insecure. So the impetus was really to try to tease out where we were as far as identifying our most severe cases of food insecurity among the clients that we, served. And so in the initial looking at the data, it wasn't really individual to individual as it was more to the regions. We have 12 area agencies on aging, and it was really looking at, okay, where are regions that have the most cases of severe food insecurity that we needed to address, and probably targeting of funding and things like that. And so the difficult part is, okay, on an individual level, and okay, now I'm going to really get into the weeds here, but I promise you we won't go too far in. This is the thing. The reason why one of the key parts of this session is to just really reiterate is that you cannot make an assessment about your progress by looking at food insecurity alone. And the reason why is, like in our case, Division of Aging Services, throughout the network, the provision of a meal is a critical solution, but you've got to understand that if we're, for the most part, providing one meal a day for a senior, right? Whether it's a home delivered meal or a congregate meal, you knowing what that food security score is doesn't tell you whether that meal that you're providing is their only meal, or does it now make 2, or does it now make 3, right? And so even if you see a person who from year to year has now made a change, that is a positive one, or it is a decline. You in isolation cannot use that and say, all right, our one meal is making a difference in isolation. You've got to know things like, does a person get SNAP benefits? What is the structure of their household? Are they a grandparent raising grandchildren? What are the other potential factors that would, as Kathryn was sharing with us, potentially impact why a person might be food insecure or food secure, right? And so you don't want to lay so much into that screen by itself, but it's certainly a trigger even if in that provision of a one meal, as an example, they're still presenting as food insecure. Because then you need to be thinking about, maybe there's nutrition counseling that needs to be involved. Maybe there is some other issues with dentition that maybe need to be considered. That maybe they need to be referred to participation in the SNAP program, or if you find out that they have SNAP already, what kind of benefit level? This now requires partnering with other partners to say maybe they need more benefits, because there's many other factors around why a person is food insecure, as we shared in this session, that gets at it. And that's why this alone will not, tell you the full story. Let me see. There was a lot of parts. I want to make sure I didn't miss anything, and I probably did. But let me see.
I think you got it for the most part. Yeah.
Okay, good deal.
And that kind of leads to this next question, is anyone assessing whether the food insecure adults who are already getting SNAP, and if so, are they assessing whether the SNAP amount is correct? So I know that you've had a background with the SNAP benefits as well.
Right, right. Okay, so is the question whether um, a person is getting the maximum amount of benefits? Is that what the question
It's
is?
like if they're assessing that they're food insecure and they're already getting SNAP, is there a way to assess whether or not the SNAP amount is actually correct, or if it needs to be increased?
Well, the big answer is yes. Now, what supports and access there are to do that varies, right? Because I know that there are some people who are case managers or option counselors, they have other roles in which they may have some training to be kind of dive into that. But this is where, those partners and coalition building, partnership building is critical. Having people who can come in and do assessments also on whether a person is getting the maximum amount of benefits is great, especially knowing that often most states, I know I can speak to Georgia, I mean, you would have to, at most, a senior would have 12 months of benefits, if they're on a fixed income as an example, or some other variation. And so with that being said, when they're doing their renewal, making sure, not necessarily you in particular, but whoever, whether you're talking about your advocacy partners, or those who you have in-house who might do screenings, to make sure there aren't any changes as far as housing expenses, as far as medical expenses. There's really a lot of key things that seniors can actually include when they apply for SNAP benefits. And I'm going to try not to go too deep into this because I'm getting kind of excited about this part of it. But that really needs to be considered, that oftentimes many seniors are not getting the max benefits because they're not including those other things. But this is where you really want to get your partners in that kind of can get into the weeds about that, to make sure that that's what the issue is. And also understanding that these screenings really also are talking about financial constraints, right? So it may not be that SNAP benefits is where the gap is for this person. This person could be spending too much as far as their utility cost, and maybe looking at where they can get, I'm having a a moment where I can't think of the term, but where you can get assistance for your light bill or water bill, if you have some different things like that. That may be the difference for a senior. Maybe they're overspending on some other bill. I am a big fan of SHIP and being able to actually, have seniors say, do I have the right medical coverage for my needs? And maybe that's where they're overextending, And so it's really that balance. And you may not be able to do this, but this is what we're talking about, this holistic approach of a senior to really understand why a person may be food insecure, maybe out of even the scope of just a meal alone.
Mhm. Well, and this next question, all of these questions seem to address the ability to afford food, but how can we screen for the other barriers, like I mentioned earlier in the presentation, whenever they're not able to eat? And there's often, I know that there's a lot of screens that involve whether they're able to chew, whether they're able to grocery shop, and those you sort of got to be able to bring all those in and really identify that to make sure. And I don't know if you want to delve into that a little bit further.
Right. Your IADLs and ADLs, and just understanding basic, function, because those will be your other, light bulb moments where you're like, wait a minute, I'm seeing a pattern here, because oftentimes, and I'll go to the senior center level, is that for those who are seeing seniors in this congregate meal setting, you're seeing a senior, and often you may be the person providing the transportation for a senior to go to the doctor's office, to go to the grocery store. And so those are cues for those people, especially who are around that senior, if we're talking about it on an individual level, to start to see, I'm seeing some changes. They're not going to the store, they're not, as mobile. And so maybe that implies implication of their ability to even prepare meals, right? Because yes, we're talking about the financial constraints, but, and that's what food insecurity, these screenings are looking at. But all these other factors, if you just in isolation look at why someone may, not be eating, it could be tied to that as well. But part of that is kind of using all those supportive assessments to really see, okay, how does this line up? What are the other things that a senior is using to kind of make it from day to day and month to month?
So how often do you perform the screens in Georgia?
Yes, so the screens would be at intake. They would basically the examples that are put forth in the slide when we talk about when to do the assessments is actually when we do the assessment. So it's at intake. It is for the most part. So it's at intake for sure. We do it annually. If there's a change in service as it might relate to food, right? If you have a person, we've had some shifts of people from congregate to home delivered meals, those kind of changes at which we're doing those assessments of food insecurity. What would be the ideal, and this is really difficult when you talk about potentially how many number of clients you have though, is to kind of look back if you've made some kind of judgment call of what the prescription might be, and I'm using prescription in a very loose term, is okay, we've identified a person who's food insecure, we're going to provide meals once we've decided, we've realized that, okay, they can eat, all those kind of things. And then, whether you're looking at a 90-day period out, or a 90-day period, or even as short as a 60-day period, is saying, is this making a change? But in full transparency, that is not in our written policy to do that. But we're really encouraging that if you have that opportunity, the goal is to say, it's not just to do the assessment, right? It's to be able to say, okay, is this having an impact? And because we're measuring at a 30-day period, you can see where the potential is to make a difference. On an individual note, most of my work has been, I did research in this space where I looked at what the implications of having SNAP benefits and changes in food insecurity. And my frame of reference was between 3 to 6 months out after getting SNAP benefits, and measuring food insecurity in those periods. And even in that short frame, you could see that just the provision for people who had the max amount of benefits now infused into their household budget, it did make a difference for them. Of course, what that means going forward, there's things that kind of level out, but that's beyond the, my study frame. But that tells you that you can see differences, but in full transparency, it's got to be difficult when you're talking about lots. I had 10 clients that I had to kind of maneuver with, but many regions have way more than that, right? So that annual, looking at other assessments, what is prescribed working? It could, if it's not a meal or if it's SNAP benefits, those are triggers that you can immediately see, okay, a person had no benefits, now they do, right? And so those are the ways at which you can start to check off and see, is this working? And hopefully correct if not.
So is the 6-item survey available for general use?
Absolutely. So one of the references you'll see is the reference to the paper, which we had the initial assessment validated. And so those questions are there. And so I want to make sure. So one of the questions earlier was about distinguishing the short form that USDA came up with, the 6-item. I do want to state that the subtle difference with the Georgia survey is that, let me make sure I do a quick click so I can kind of see, so in theirs, they actually combine cutting the size of the meal and skipping a meal. And then ask in the follow-up question, how often did this happen? So we don't get into, how often this takes place, but really distinguish between the size of the meal and skipping the meal as a distinction of how we look at it for the Georgia survey. And we've been able to, in a number of publications, to kind of see that there are very distinct differences in using this assessment. Our last publication these days are kind of running together for me, but we did a recent paper that looked at the implications of the nutrition services that we offer, as well as SNAP benefits, which is part of our sister agency that provides that, all within Department of Human Services, and seeing the implication for our clients that are sort of in the system during the early stages of the pandemic. And what it showed is that there was a protective effect of being able to have access in this system where they would be provided meals on a consistent basis, and even for those who were receiving SNAP benefits. So in this case, we got to see in real time the implications of doing these assessments and seeing, how important it is to have the framework of nutrition services, and of course, SNAP, which is huge when we're talking about addressing food insecurity.
Okay. Let's see the next question. How are patients referred for the screening? So I would assume that once they are, they screen for food insecurity. And the next webinar, we'll talk a lot about referral, but if you want to quickly, we have just a couple more minutes and you might want to be able to answer a little bit of that.
Gotcha. Okay, so my short answer is, if you're calling in and asking about meals, we're asking you the 6-item questionnaire. If you are in the system, either getting if you're getting home delivered meals, we're checking in and asking you these questions. So it's not a referral to take this assessment. If you're getting a meal, we've been asking you these questions. So that's kind of the frame. All of our clients are getting that. And so we're getting this rich pool of data to understand, just as I gave this whole big speech about not just looking at this in isolation, but in this with others, we're able to see whether we're helping to move the needle a little bit and addressing the needs of our seniors.
And I think we have another question. How might this be helpful for food pantries to identify those in need of home delivered meals, since they are often volunteers and not caseworkers?
Indeed. I mean, so in that type of setting where certainly oftentimes, and I've had the opportunity to be in many food pantries as I recruited for my research study, is that you got people who just want to come in, get their food and be on their way, right? And so you also have to take that into account. And so maybe a 2-item questionnaire might be more feasible in that setting. And so that way you at least flag, and I can't say I've done a lot of work with looking at pantry people in the sense of people who are going to a pantry, but I find that they seem to have a level of consistency. Oftentimes, because you've got to fill out the forms and kind of be in the system. You can't just show up at a pantry, many of them. And so that way you have a ready pool to be actually to see the implications of that. What I ask always, if you're going to do an assessment, think about what it is that you're planning to do with that, right? Are you going to refer them to apply for SNAP benefits? That is huge, because pantries, for the most part, we're really in that emergency food sector. And so the goal is not to have committed people who are just using the pantry as their source of food ongoing, right? And so you want to be able to say, okay, I see this person continually coming back. What are some other things that we could potentially refer them to if they're open to it, to be able to get them in a level of consistency that doesn't require that they have to come to the pantry every week or every so often.
And would you happen to know if older disabled Medicaid waiver recipients get screened with food insecurity? That
We
wasn't a question.
provide non-Medicaid services, so I will refrain from,
Okay,
my answer is no. So I'll say no.
Yeah,
Yeah.
I was just wanting to make sure. I was going to ask that just in case, because I don't have that answer either.
Right.
So how can agencies who don't serve meals use this tool, or is this or could this be a resource? And I think they're thinking about like intensive case managers in
Absolutely.
those areas.
Absolutely. If I think it's great if you're assessing people who are low income. But the key thing is you never want to just do an assessment to do an assessment, right? So if you're going to incorporate this into your holistic look at clients that you serve, you should have ready in mind what happens if someone presents to be food insecure, right? What are your next steps, right? Because it's that whole public health, mantra that it's you tell them they have it, now what, right? Are you going to refer them to a service? Who are your partners that you're going to now do something with because you have this knowledge? And so with that, I absolutely recommend that we should have that, especially because we're not able in any capacity to serve every person in our regions who are in need. And so you may be meeting a client that won't be getting to a senior center, that won't be getting to these other connective points. And so you being able to flag them may be a way to refer them to the nutrition services that are in place, because you are a trusted connection for that person. So I'm a big proponent of that, but just make sure you have that next referral of what happens once you identify someone.
Okay, thank you. We went the full hour, and I told you we'd probably get done early, but we had some amazing questions. And thank you so much, Dr. Walker, for your answers. Any further questions or any questions we didn't quite get to, we'll try to reach back out and answer some of those. Feel free to reach out to us if you have any questions. This webinar will be sent out. The recording will be sent out to all attendees. And have a great rest of your day. Thank you, Dr. Walker, for being a part of this.
Pleasure. Thank you.